Vision screening for school children ensures a successful learning experience. School nurses perform a vital role in efficient and effective screening. Correction of a child's vision problem makes a vital difference in a child's school experience.
The nurse did a quick eye exam on my daughter, or on Shantae, and she noticed that it was really bad. Her writing was really big. I mean, it was like half a page. And then after she got her glasses, she started writing them smaller. And then her reading, instead of holding the book up here to her face, she actually held it at a normal level to where she was reading at a normal level.
I'm really grateful that the school nurse did everything that she had and sent Shantae through the right channels to get her vision resolved, because it's been leaps and bounds, to say the least.
I do so well because I got my glasses.
This tutorial illustrates the importance of school vision screening and presents techniques to accomplish it efficiently and effectively. It is not intended to represent the single best method in school-based vision screening, but rather to illustrate effective vision screening using the most commonly available methods. Rules and regulations regarding vision screening vary by state. Use the information presented in this tutorial in combination with your state's rules and regulations to guide your practice.
In school, we have access to a large number of children over a large age span. And some school districts also have preschoolers included. So it makes real sense as a public health screening measure to screen children in school. It's called To See or Not to See, Screening the Vision of Children in School. I was asked to do it by the National Association of School Nurses to update their vision screening procedure manual. And I agreed to do it, providing that it would be more than a procedure manual. It's my view that nurses should know as much about the various eye conditions they're screening for as they do about diabetes or asthma or any other conditions of children that they treat in schools. I also agreed to do it only if it was reviewed by both a representative from ophthalmology and optometry. A successful school vision screening program has to have a competent screener, person who understands not just how to do it, but understands the background of various visual disorders. There are three. To identify the presence of impaired vision in school children, to assess the ability of the two eyes to work together, and to detect the presence of structural abnormalities.
Refractive errors. What is myopia? Myopia is a refractive state in which the light rays entering the eye fall in front of the area of best focus on the retina. Myopic children are nearsighted and see poorly when looking to distance. Hyperopia is a refractive state in which the light rays entering the eye fall behind the retina. Hyperopic children are farsighted, meaning that they have better vision at distance than near. Children with significant hyperopia have trouble maintaining a clearly focused image at near. Small amounts of hyperopia are well tolerated by children and do not need correction with glasses. What is astigmatism? Astigmatism is a refractive state in which the light rays are distorted as they enter the eye. Some rays are focused behind the retina and others in front. Vision is blurred at both distance and near. Amblyopia. Amblyopia is a loss of vision in one or both eyes that occurs because the brain suppresses the image from the eye during the critical period of visual development. What is the critical period? The critical period of vision development in the brain starts at birth and extends to approximately 9 years of age. During this time, the brain has plasticity, and the occipital lobe and visual pathways develop in response to the visual input provided. It is crucial that amblyopia be detected early so that it can be treated effectively during the critical period of vision development. Once the critical period is over, it is difficult, if not impossible, to treat amblyopia effectively. The consequence of untreated amblyopia is irreversible vision loss. Several causes of amblyopia exist. In refractive amblyopia, a substantial refractive error in one or both eyes causes blurring of the image received by the brain. The brain suppresses the image because it is not clear. Children with refractive amblyopia are frequently significantly farsighted and often have significant anisometropia, or a difference in refractive power between the eyes. Children with refractive amblyopia do not typically have eye misalignment or vision complaints. Vision screening examinations are essential to identify these children. In strabismic amblyopia, the presence of eye misalignment, or strabismus, results in two images competing for the attention of the brain. The brain selectively ignores the image from the misaligned eye to avoid double vision, and the connections between the eye and the brain do not develop. In deprivational amblyopia, the projection of a clear image on the retina is obstructed in some way. The obstruction might be a dense cataract or a droopy eyelid. The brain ignores the eye with the degraded or absent image. Fundamentals of a successful vision screening program. Examinee can perform tests reliably. Examiner is knowledgeable and competent. Examiner has no vested interest in the result. Examiner uses best methods available. Results are reliable, sensitive, and specific. Criteria for referral for a comprehensive examination by an eye care professional are clear. Results are clearly communicated to parents and guardians. Opportunity for a follow-up examination is accessible and affordable. Mechanism to ensure follow-up is in place. Results of the comprehensive examination are communicated to the school screener for program evaluation purposes. Intervals for screening. Repeated vision screenings throughout a child's school career are most effective in detecting eye problems. Screening intervals may be mandated by state screening recommendations. If not mandated, screening of available preschoolers and all kindergartners should be performed. Screening should continue every other year in grades 1 through 12. Students transferring into a new school should have their vision checked upon transfer. How to check children's vision. The next part of the tutorial will demonstrate several screening methods, highlighting the advantages and disadvantages of each technique. Subjective visual acuity screening with eye charts. Subjective vision screening involves identification of letters or symbols called optotypes. For testing distance vision, the optotypes can be presented on a wall chart, a flip chart, a portable illuminated cabinet, or a computer screen. Optotypes used for testing near visual acuity are presented on a handheld card.
Well, traditional vision screening has been around for a long, long time, and it's essentially, as a technique, has been unchanged for decades and decades. It involves the use of wall-mounted charts or charts placed in portable illuminated cabinets that are electrified. Traditional screening now also involves the use of stereoscopes or stereoscopic vision screeners because they have been used for so many years. We can classify them as traditional. Non-traditional, or the newer technologies in my view, involve some of the photo screeners, the portable autorefractors, and some of the very new stuff combines photo screening and portable autorefractors into one. The traditional wall-mounted charts or charts in portable illuminated cabinets remain very good if done using the appropriate optotypes, the appropriate distance, assuring really good occlusion. Occlusion is such a key thing. Using the right tests for the the appropriate age group children, and lighting is absolutely key. There has to be optimal lighting. If all of those things are done well by a vision screener who knows what he or she is doing, we can feel rest assured that the vision screen will be a reasonably reliable one, and the school nurse can feel good after a rescreen about making a referral for a child who may be in need of that.
Testing should be performed monocularly. Ideally, the non-tested eye is covered with an adhesive patch or tape. If a patch or tape is not available, care must be taken to prevent peeking. Occluder glasses can be fun for younger children. If the child wears glasses for distance, the glasses should be worn during the test. Glasses intended for use when doing near work or reading glasses should not be used when testing distance visual acuity. Try to screen children in a quiet environment. At the start of screening or in a separate session, familiarize the younger child with the optotypes being used. If a child is unable to reliably name or match the optotypes, switch to an easier set of optotypes. Start testing by warming up the unpatched child on big optotypes to build confidence. Offer encouragement and praise.
Good.
Then proceed to monocular testing. To enhance the performance of young or cognitively impaired children, try the following. Point to the optotypes on the chart. Allow children to match the optotypes on the chart to those found on a handheld card. A shorter testing distance or flip chart can also facilitate testing in younger children. Optotype choice is important. Optotypes should be clear, standardized, and of similar difficulty to identify. Optotypes should not reflect a cultural bias. A desirable optotype for pre-literate children is Leah symbols. Leah symbols are desirable because each optotype blurs similarly as it becomes smaller, eliminating the variability in the ease of identifying individual pictures. Leah symbols are not culturally biased. A second desirable method for testing the slightly older pre-literate child is limited choice letter identification with a chart containing only the letters H, O, T, and V. This is the HOTV chart. Children who cannot name the letters on the HOTV chart can match them to a handheld card. Several undesirable symbol charts for pre-literate children are unfortunately still in widespread use. These include the Allen figures, the Sjogren hand chart, the lighthouse chart, the blackbird chart, and the illiterate or tumbling E chart. These charts are undesirable because the optotypes are non-standardized or presented in a culturally biased or confusing fashion. Desirable optotypes for older children are Sloan letters and numerals. Snellen letters are less desirable because they are more difficult to discern. Optotype presentation is also important. Optotypes should be presented in a full line whenever possible. Do not cover or mask the other optotypes in an attempt to enhance performance. The presentation of single, isolated optotypes can overestimate visual acuity, leading to the underdetection of amblyopia. However, single letters or symbols can be easier for younger or cognitively impaired children to identify. When a single optotype is presented, it should have surround bars around it. The surround bars prevent overestimation of visual acuity and underdetection of amblyopia. Failure criteria are age-specific. The American Association for Pediatric Ophthalmology and Strabismus recommends pass-refer criteria based on critical line testing. The critical line is age-dependent. For age 36 to 47 months, 20/50 is the critical line. For age 48 to 59 months, 2040 is the critical line. For age 60 months and older, 2032 or 2030 is the critical line. Children must correctly identify the majority of optotypes on the critical line to pass the test. Children not reaching this threshold should be referred. Advantages of traditional screening. Excellent data when well done, time-tested and well-studied, excellent charts are available, the cost is low. Disadvantages of traditional screening. It's slow. The success of the screen is examiner, method, and environment dependent. Stereoscopic vision screening machines. In stereoscopic vision testing, the child looks into a machine that presents tests of distance acuity, near acuity, depth, and color perception. Several brands are available.
Stereoscopic machines have some definite advantages. I used to use one and did for years. They purportedly screen several visual functions in one piece of equipment: distance, near vision, color vision, binocular vision. They don't require any external occlusion. They're quick and easy, which is really nice for the itinerant and very busy school nurse. And they're easy to use, and children like them as well.
It is important that the child be positioned correctly at the device. Watch for excessive head movement that might indicate that the child is unable to use both eyes simultaneously because the interpupillary distance is too large for the child. Proceed with the test according to the manufacturer's instructions.
I think that their shortcomings regrettably outweigh their advantages. Some of the shortcomings are that screening distance vision, the machines have been reported to over-refer, that is, that they have low specificity, which results in too many referrals, false positives in other words. And that may have something to do with the fact that there's an artificial 20 feet that's established in the machines, set up by the way the mirrors work, but I don't know why. That's just been a report. Similarly, then, if the distance vision screening is compromised, the near vision screening with the use of a plus lens may be compromised, because plus lenses to look for hyperopia are used with distance optotypes or distance targets, not near targets. So that may be an issue for that particular facet or function of the machines. There's also slides that are placed at near vision, an actual 14 inches, but most eye professionals recommend against using them with young children because very young children can accommodate long enough to get through the near slides or near card, if you use a near card, and the high hyperopia will be missed.
Rescreening subjective acuity test failures. Subjective acuity testing requires considerable understanding and cooperation on the part of the child, particularly the younger or cognitively impaired child. Therefore, it is recommended that children who do not pass the screening examination be retested prior to referral. Repeat screening should be performed on a standard chart. The interval to the repeat test may be mandated by state vision screening guidelines. If not, reasonable retesting intervals for children failing subjective vision screening are: age less than 4, retest within 4 months. This interval allows time for maturation and better test performance. Age older than 4, retest within 1 month. Objective screening devices. Objective screening devices, commonly referred to as photo screeners, do not measure visual acuity. Rather, they detect conditions that contribute to the development of amblyopia. Photo screeners work by using an optical image or an invisible wavelength of light to assess for the presence of significant refractive errors, opacities that block transmission of light to the retina, and abnormal ocular alignment. Objective screening devices typically fall into one of two categories. Autorefractors measure the refractive error of the eye. Photoscreeners use a flash to capture an image of the red reflex of the eye. The quality of the light reflex is interpreted automatically or by a trained examiner. Objective screening devices are very useful in children who can't perform subjective visual acuity screening. They may have potential in screening older children as well, but are currently used primarily in pre-literate children. The child looks at the machine and an image of the light reflexes of the eyes is obtained. Proper alignment of the head is important to obtaining accurate readings, and children need to hold fairly still for a good image. Age-dependent referral criteria are set by the manufacturer and are based on the refractive power of the eye, the difference in refractive powers between the two eyes, and the presence of misaligned or obstructed light reflexes. Several objective screening devices exist, and the technology is continually evolving. Advantages of objective screening devices: quick, easy for young and developmentally delayed children, require minimal cooperation, potential for very accurate data. Disadvantages of objective screening devices: do not give a visual acuity. Obtaining and interpreting the images can be user-dependent. The equipment can be expensive. Rescreening objective vision screening failures. If the photo screening test was well performed and the child met criteria for referral, there is no need to rescreen. If the child failed the test because participation was poor, the child should be retested, either by photo screening or by subjective visual acuity testing. Photo screening devices represent exciting new technology in vision screening, particularly useful in identification of the pre-literate child who is at risk for development of amblyopia. Other elements of school vision screenings. These elements need to be performed one time only, preferably early in a child's school career. They are important as an adjunct to visual acuity testing. The requirement for them is variable by state. Near vision. The usefulness of testing a young child's near vision is questionable. Young children have a great ability to focus or accommodate. Even children with significant uncorrected hyperopia can perform well on near visual acuity tests and therefore would not be identified. And children with uncorrected myopia see well at near, so would not be identified by near vision testing. Stereo acuity tests. These tests assess a child's depth perception. The child wears polarized glasses, and if the eyes are in good alignment and the visual acuity is good, the child will see the images on the plates in 3 dimensions. RANDOT has tests appropriate for school-aged children and preschoolers. Inspection for eye misalignment. The child should be observed for the presence of strabismus. Observation of the light reflexes can facilitate the inspection. Asymmetric light reflexes might indicate the presence of strabismus. Color vision. Some states mandate color vision testing, and teachers are often interested to know whether a child who is having difficulty with color-oriented tasks is colorblind. The most common type of color blindness is red-green color deficiency that affects 8% of boys and less than 1% of girls. Pseudo-isochromatic plates are the most appropriate means to test for color perception. The plates are comprised of a pattern of differently shaded dots. If a child has normal color vision, some of the dots will appear dissimilar in color and a number or figure will be identified. If a child is color deficient, no pattern will be identified because all the dots will appear similar in color. Special circumstances. The special needs student. Choose a test that's appropriate to the child's developmental stage. Use objective screening devices if available. Some children may not be testable. These children should be referred for a comprehensive eye examination. Children with learning disabilities. Children with learning disabilities have no higher incidence of eye disease. There is no evidence that focusing problems or defective eye teaming cause learning disabilities. Vision screening examinations with referral of failures are an appropriate part of the evaluation of the learning disabled student.
What I would say to school nurses is that you have an opportunity to really help children by doing the best possible vision screening that you can do, by identifying potential vision problems and getting these children in and under treatment.
School nurses play a key role in the success of children in the educational setting. We hope this tutorial has encouraged you to provide the best practices in school vision screening. Good vision is a cornerstone to school success. Identification of children with potential vision problems and referral of those children to appropriate resources helps ensure the success of children in school.